So why did you write this book? Who do you want to read it?
A lot of the commentary around what happened, what went wrong, I think was very political. It was focused on a lot of the political mistakes that were made. I don't think anyone started to delve into the more systemic problems, more systemic shortcomings, the structural features of government that I think made us excessively vulnerable to the pandemic. And I wanted to start to tell that story. I think if we're going to make sure we're better prepared if this happens again, and this will happen again, we have to start examining what are the features of government that failed, why were we made so excessively vulnerable, and there certainly were political shortcomings, but there were a lot of things about the way the agencies were structured, the way the agencies responded, the kind of planning we had done in the past that we thought would better prepare us for this pandemic, that weren't up to the test.
So this is something you want public health leaders, lawmakers, to learn some lessons from.
Yeah, I think at some point we're going to start to reflect on what went wrong. We're going to put together commissions, put together authoritative groups to try to, come to some consensus about what we need to do differently to better prepare for the future. And I want this book to be part of that dialogue. This was my attempt to, lay out what I think some of the things that left us vulnerable were and how we can start to repair them, how we can start to build better resiliency against these kinds of threats going forward. So I would hope that this book is going to be part of that dialogue.
You have some personal anecdotes in there. In fact, you start the book talking about the attacks on 9/11, and you were a young resident up in New York City. Why did you start there?
Yeah, so I was on elective that month. I remember the day, and so I was sort of swing labor. I was an extra hand. I wasn't assigned to a floor, and I was post-call. So I had come off call the night before. We saw the first plane hit the World Trade Center, and then when the second plane hit, I got called into the hospital. And I spent the day working the floors, mostly trying to discharge patients because we thought that there would be a flood of patients coming into the hospital, so we were trying to clear up beds. And then at night, I was assigned to a triage center in Chelsea Piers, downtown, near the fallen World Trade Centers. And when I got there, I walked into a field house, and it was a cavernous field house, and they had set up at some point over the course of the day basically the equivalent of hundreds of hospital beds, but not just staffed hospital beds, but these were surgical beds. They had advanced medical equipment in hundreds of stations. And it was like nothing I've ever seen before or since. So somewhere, around New York City, someone had made a decision that New York needed to be prepared for a mass casualty event, and they had mothballed all the equipment that would be needed to do it, to handle it, and they had mothballed the logistics to set it up within hours. And the reason I told that story was because nothing equivalent really existed here. In New York City, we had the first attack on the World Trade Center. There was a decision made by someone at some point that New York needed to prepare certain capacities. What I saw was part of that very clearly. And when COVID came, we had this sort of illusion that we had prepared for a pandemic and that we had certain capacities that had been mothballed and preparations that had been made, but they were ill-suited to the crisis we faced. And even the ones that were sort of appropriately measured to what we were facing weren't ready. A metaphor for it was the masks and the ventilators. We had stockpiled, not enough, obviously, masks and ventilators, and they didn't work. The ones we had didn't work. The masks were expired, the ventilators hadn't been serviced. And that's just a sort of a metaphor for the lack of preparation. But I think we didn't really have the foresight to understand that a virus could threaten us in this way. We had planned for a pandemic flu. I had been part of some of that planning back in 2003 and 2005 when I was at FDA during my first stint, but we didn't really understand how the planning that we had engaged in for influenza wouldn't be applicable to a coronavirus.
So we prepared for the wrong threat.
We prepared for the wrong threat, but even if we had prepared for the right threat, the preparations still weren't adequate. We still didn't have the kinds of capacities we needed to, forward deploy the medical resources that would be required. I think we didn't envision that in the setting of a global crisis, there would be a global run on the supply chains that we needed to properly supply the medical equipment. Just the swabs used to conduct diagnostic tests, we ran out of them. One of the bottlenecks to conducting more diagnostic testing wasn't that we didn't have the PCR machines, the sophisticated machines, wasn't that we didn't have the labs, we didn't have the swabs to actually collect the samples. So we didn't understand that if you had a global crisis of this magnitude, suddenly the supply chains that we relied on would be pulled on by every country at the same time, and we couldn't rely on them anymore. So what we needed was just a whole different mindset. We needed to build domestic capacity to do the production domestically. We needed to keep the the apparatus that we thought we would need hot, not just warm. We couldn't just build it and mothball it. We needed to keep it operating. We needed to keep it functional. We needed to have a logistical capability to deploy these tools. We didn't have the ability to scale diagnostic testing because we couldn't deploy enough testing centers. We didn't have the ability to mass vaccinate the population because we didn't have any mothballed capacity to set up vaccination sites. And that's what I saw on 9/11. I mean, obviously, small microcosm was a city. It wasn't across the whole country. I mean, the country wouldn't have been able to deal with a crisis of that magnitude, but someone had thought about how to build the apparatus and the means to deploy it very quickly for a certain contingency. We didn't do that against a viral contingency, even though we had anticipated and expected that at some point we'd be challenged with a pandemic.
So it's been 18 months now since we were hit with this pandemic. In the book, you write the next one very well could be a new variant of a bird flu. Are we as vulnerable to that kind of new threat as we were to COVID-19?
I think we're still vulnerable. There's nothing that's really been changed with respect to our posture. I think where we might have less vulnerability is that, fool me once, we're more aware of the threats that could emerge from around the world. We're going to respond more quickly. Next time we see an emerging infection, we're not going to wait 6 weeks or 2 months to start manufacturing a diagnostic test. So we're going to make certain decisions up front that could have been made earlier in the setting of COVID, weren't, because we didn't properly anticipate the threat that it posed. I think next time, we're going to be more apt to do too much and not too little when something emerges. But in terms of the capacities that we need to respond, I don't know that we're any better in terms of our ability to actually mobilize the sort of manufacturing and the distribution capacity that we're going to need. We don't have the infrastructure to do that. Where we're better probably is that we've validated some of the technology that we would use against a new threat. So the idea of fully synthetic vaccines, being able to pivot very quickly to a vaccine. A lot of the technologies that were sort of available that allowed us to pivot very quickly to the development of countermeasures in this instance now have been validated. We were at a sort of a technological inflection point in the setting of this pandemic with the technologies we use to develop our vaccines and some of our therapeutics.
That
And
was
now
just luck, is what you're saying.
we were at the cusp of, we were sort of bridging two scientific states. If this had happened 4 years ago, we would have developed our vaccines the way we traditionally develop vaccines. We would try to grow the virus in cell cultures, the same way the Chinese developed their vaccine. You grow the virus in large quantities in cell cultures, you inactivate it, you cleave off the proteins, and you basically put the virus's proteins in a syringe, and that serves as the vaccine stock. That's how we make flu vaccine. What we did in this case was we were able to derive vaccine constructs fully synthetically just off the sequence data alone. So if you look at Moderna's vaccine, Pfizer's vaccine, where I serve on the board of directors, even J&J's vaccine and AstraZeneca's vaccine, the constructs were derived from the sequence. They didn't need the live virus. They didn't need to grow the virus. So we were right at that inflection point where that technology was becoming available, and that allowed us to pivot to vaccines very quickly. If this had happened 5 years from now, that technology probably would have been mainstreamed. And what happened in the setting of the pandemic is we've sort of accelerated our way through that technology curve because we've developed the vaccines and we've deployed them. 380 million Americans have received a vaccine.
So after the 9/11 attacks, we had this wholesale, rejiggering of the U.S. government, and you had a 9/11 commission. Do you think in this setting now that that kind of commission is even possible?
I think it's necessary. I think we're going to have to do it.
Politically, is it possible?
It's difficult, and I think it's difficult for a variety of reasons. It's probably, I've asked myself, why haven't we done it yet? I mean, there's been some groups that have come together, National Academy of Medicine, other groups. The Biden administration put out sort of the blueprint for what a pandemic strategy would look like. My assumption is it's too early. We're still grappling with this pandemic. So I keep telling myself maybe it's too early, and that's why Congress hasn't convened a commission. That's why we don't see a bipartisan group emerging to try to do this work. You've seen some legislation proposed, but nothing that's sort of a grand effort to really come up with a comprehensive approach to how we're going to prepare better for the future. I think the other thing we're going to have to grapple with, it's not just a question of the politics of the moment and the inability to get a consensus around big issues. And that is a problem right now. I think that the public health establishment as a whole has taken a hit in the setting of this pandemic. And this isn't just a sort of Republican, Democrat, conservative, liberal thing. I think that there's a lot of people around the country who feel that the advice they got from public health officials wasn't precise, changed, wasn't wasn't formulated in a way where it was sort of immutable, wasn't carefully explained, wasn't propagated in a way that it could be assimilated into people's lives. How do I wear a mask? What mask should I wear? When should I wear a mask? When not? And things changed. And so people were confused by it and lost confidence in it. And I think that there's going to be part of the dialogue we have around how do we prepare better for the next pandemic, I think, unfortunately, is going to also be a discussion of what role should public health agencies and public health officials play, and how much should policymakers really be overseeing what they're doing in the setting of a crisis? Should they really be in control? That's going to be a hard discussion, because if we're not going to sort of support the primacy of public health and public health officials in the setting of a public health crisis, it's hard to start. It's hard to get started. And I think that's going to be the first bridge we need to cross as we step into this.
Well, the elephant in the room with all that politically is also who was president at the time of the pandemic. And I want to come back to that, because personality obviously was a factor here. But your broader point is that this is not a book about Donald Trump's leadership. This is a point about the overall healthcare system in the United States. You say the CDC, which is supposed to be the gold standard public health agency, doesn't have an operational capability to manage a crisis of this scale. So if the CDC doesn't, who does?
Nobody does. There was a perception early in this crisis that the CDC has this, that they would have the capacity to develop a diagnostic test and deploy it and gather the data that we would need and do the analytics to try to gauge, sort of scope out what the contours of the response would be. And they would be able to deploy the diagnostic test and deploy the vaccine and stand up this infrastructure. They're not a logistical organization. CDC has a very retrospective mindset. It's a high science organization that does deep analytical analysis of data that's oftentimes out of sync to when the decisions need to get made. They're not the JSOC. They're not the Joint Special Operations Command. They don't surface real-time information to inform current policymaking.
They're not a quick reaction force.
Right. They'd rather take the data, analyze it for 4 months, and publish it in the Morbidity and Mortality Weekly Report. And the idea that they were going to be able to mass manufacture a diagnostic test and forward deploy it, they contaminated their own tests. So they botched the manufacture of their test. But even if they had succeeded, even if they had gotten that test out on time perfectly, what they were going to do, the blueprint was that they would develop tests for the public health labs. Well, the public health labs in this country, there's 100 of them. They can each do about 100 tests a day. So even at full tilt, if everything had gone perfectly, we'd be doing 10,000 tests a day. We needed hundreds of thousands of tests a day. So what had to happen early on was we needed to turn to the commercial manufacturers, like South Korea did, and start mass producing tests.
We needed to turn to private industry earlier in the pandemic.
We needed an all of the above approach. We needed to get the public health labs stood up. We needed to simultaneously get the clinical labs stood up, labs inside hospitals, and we needed to get private manufacturers developing test kits that can go in every commercial lab around the country. That needed to happen in January. Certainly by the end of January, we had enough awareness that this could be a global pandemic, that someone could have hit the red button and said, we need an all of the above approach here. But CDC had the ball. The CDC was following their standard blueprint. Their blueprint could keep up with a slow-moving outbreak. It was quasi-sufficient in the setting of Zika, which was a slower-moving infection, but in a fast-moving epidemic like this, it was unmatched. And, in fairness to CDC, there were a lot of policymakers who assumed that they would be able to complete this mission and wrongly assumed what their capabilities were. Now, CDC should have raised their hand and said, we really don't have this. I think.
Why didn't they? Is that a failure of Robert Redfield, the head of the CDC at the time?
I think it's very difficult for an agency to have this self-awareness that they don't have the capacity to respond in the way they're being asked. And I think it's very difficult for an agency to self-organize differently in the setting of a crisis. And so that's asking a lot of them. Ultimately, there was a recognition that you needed to marry the sort of scientific capability of government agencies with the logistical capability of something like a FEMA or a DOD when we created Operation Warp Speed to try to accelerate the development of a vaccine, because that was a marriage between NIH, the scientists, FDA, the regulators, and the Department of Defense. The Department of Defense brought the capability to know how to scale up manufacturing and scale up distribution. We needed to do that at day one. We needed to get FEMA and the DOD engaged with the CDC in trying to organize a national level response. And that was a failure of political leadership. And it was a failure of vision. But there were a lot of people who were good political leaders who wrongly assumed the CDC had this mission.
So in terms of the American public hearing all these criticisms you're laying out, they're wondering, well, has this been fixed yet? When you talk with the CDC, you say they botched the development of a test. They stood in the way of private labs. They applied a flu model, the wrong model. They couldn't imagine looking for asymptomatic spread. They had a lack of data to back up public health decisions. That's a huge indictment. Have any of those things been fixed?
Some of them have been fixed. I mean, I think it's better because there's a recognition of those shortcomings. So those statements I don't think are terribly controversial anymore. I think people either quietly or overtly recognize the
We've
shortcomings
heard
of the agency.
Dr. Deborah Birx say that on Face the Nation. We've heard Matt Pottinger, the former Deputy National Security Advisor, say that on Face the Nation. I haven't heard a lot of officials talk about the level of detail you are right now and say we are still with a real big problem at the CDC.
Well, we haven't done anything to create a new capacity. What you're going to need going forward is an organization. If you want to have true pandemic preparedness, or you want to have better infrastructure for dealing with a public health crisis of this magnitude, you're going to need to have an organization that is in the business of surfacing actionable intelligence, has a different mindset around information, doesn't need to be the final definitive answer, but knows how to surface information to policymakers who are making active decisions.
Is this a new agency?
It could be a new agency, but I think that would be a mistake. I think the right way to do it probably is to build a capacity inside CDC, because if you try to sort of create a new agency, you're going to ignite all kinds of turf wars across Washington. If you try to consolidate agencies like we did with the Department of Homeland Security, you're stealing other agencies' authorities, and that's always difficult. I think this could reside inside CDC, but it needs to be a much different organization. CDC over the years evolved much more towards its disease prevention mission, reducing heart disease, smoking cessation, and away from its core disease control, overseas operations, the service that they have, the epidemiological service, which goes into hot zones and gets samples of viruses and brings them back and studies them and develops countermeasures. That's sort of the heroic part of the agency that's often talked about. Movies get made about it. Over time, I think that has been subordinated to the more policy aspects of the CDC's mission. So I don't know that you sort of fundamentally reform CDC. I think what you try to do is grow up a new capacity inside the organization that has a different culture, different mindset, different resources, different capability. The component that they recently created, where they created this new modeling center inside CDC, a pandemic modeling center,
The Biden administration has done
right, by
this.
the Biden administration. That could be the kernel that becomes the new flower inside CDC. I think that the mindset of that organization, the people who are staffing it right now, who come out of a national security world, could bring a new esprit de corps into that organization, and you can grow out this capacity from there. But someone needs to build it.
Well, the Biden administration has asked for $65 billion to strengthen pandemic preparedness. Congress hasn't funded it yet.
I don't think this is going to be a money problem. I think people are going to appropriate the funds. I think that it's going to be a strategy problem. And that's really what I try to do here is sort of lay out some of the foundation of what went wrong and how we could think of a different strategy. The Biden administration plan that they put forward, it's a high-level plan. It has all the right elements, but it's not a plan yet. It's more like a strategic framework for a plan. We still need to decide what that plan is. And there's going to be an intense debate because people's missions are going to be disrupted. CDC, for example, with the diagnostic test, if we wanted to have the commercial manufacturers early on engaged in developing a diagnostic test, someone had to share the samples, the virus samples with them. CDC held on to them, wouldn't give them to the commercial manufacturers. Someone needed to create some kind of funding mechanism so the commercial manufacturers had some understanding that they weren't going to just get stuck with the bill. They would have stepped forward, but at some point you needed to fund that. There's no mechanism for that. I mean, BARDA could have done it, but it's not really within BARDA's mandate. They fund very early research. So there was no agency capable of funding the handoff to a commercial manufacturer of a diagnostic test. And I keep coming back to this because a lot of our early problems really flowed from our inability to scale testing. It wasn't just that we couldn't diagnose the infections and tell where the virus was. We couldn't tell where it wasn't. So when we did the 15 days to slow the spread and then the subsequent 30 days to slow the spread, it was basically a national shutdown for 45 days, an extraordinary measure. I mean, a historic decision to shut down most commercial activity in the country. Very clearly, we needed to do that in New York. I mean, New York, the healthcare system was breached in New York. New York was on the brink of collapse. New Orleans was on the brink of collapse. Boston was on the brink of collapse. Los Angeles had pervasive spread. San Francisco and Seattle. Austin, Texas didn't have a lot of spread. Jacksonville didn't. Wyoming didn't. But we didn't know. So we shut down the whole country. And then when the virus eventually traveled to the deep south, people down there said, you know what? We're not shutting down. Now, you told us to do it in the spring, and we did. We didn't have to. We're done with shutdowns.
And that could have been avoided.
That could have been avoided because if we had a diagnostic test and we knew where the virus was and where it wasn't, we could have targeted the population-wide mitigation just to places where the virus was pervasive. And in the places where it wasn't yet pervasive, we could have used testing, tracing, quarantines to try to control the spread. It would have eventually become a confluent epidemic across the whole country, but we could have delayed that. We could have substantially delayed that, and we could have preserved the political capital in the places where the virus wasn't, so that when it got there, they would have still been willing to take the tough decisions to close bars, close restaurants, do all the things that we knew were going to control spread and buy us time until we got to a vaccine. But we basically spent that card right up front. We shut down the whole country and we didn't have to. So not having that diagnostic test what set in motion a lot of the challenges that we faced going forward.
You say the point isn't that federal health officials were wrong. The point is they were working with faulty tools, faulty data sets.
Yeah,
They
so-
didn't know what they didn't know.
They didn't understand that this wasn't spreading like flu. So they didn't have a diagnostic. So they said, well, we're going to rely on the influenza-like illness surveillance system. This is a surveillance system that was grown up in part to deal with the pandemic flu that basically monitors for people presenting to hospitals with flu-like symptoms who are testing negative for flu. But in any given week, 50,000 people present to hospitals with flu-like symptoms and test negative for flu. So you could have tens of thousands of cases hiding in plain sight with the influenza-like illness surveillance system. Plus, this wasn't always presenting like flu. So people were getting symptoms that didn't comport with flu. So if you're just looking for flu symptoms, you might not see coronavirus spreading. So they were very confident early on that there was no community spread. Meanwhile, there was widespread community transmission. And it wasn't until the beginning of March that Redfield saw a signal and the New York data picked up the phone, I talk about it, and called Howard Zuckerman, the New York State Health Commissioner, and said, you guys have a problem. It was the first time they saw an outlier. But if you look at the data all through February, and you look at the percentages of people presenting with flu-like symptoms who were testing negative for flu, it wasn't red, but it wasn't green. It was at the high end of a normal range. So if you looked at a 10-year average, it was at the high end of that 10-year average, certainly against the backdrop of what was happening around the world. We shouldn't have derived any comfort from that. And so we just didn't have the tools. We didn't have sensitive enough tools to know that there wasn't community spread. And in the absence of not having those tools in place, which would have been a diagnostic test and actually screening people, we shouldn't have been so confident that this wasn't spreading. We should have been doing things differently in anticipation that this probably was spreading. We just weren't picking it up, which in fact was the case.
You also say this should have been viewed as a national security threat, and that's how we need to think of pandemics. President Biden went out in July to the Office of the Director of National Intelligence and said generally he agrees with that. What does that actually mean, though? Have you seen the intelligence community to date react and protect us going forward? Do they have the tools needed?
Well, look, I think the intelligence community has different tools that should be focused on this mission. There's two pieces to that idea that we have to look at public health preparedness through the lens of national security. One is the domestic piece, how we prepare. Thinking about this as something that could be a low probability but high impact event, and how do we prepare about other events like that? The risk of a radiological attack, the risk of a meteor strike. I mean, we make certain preparations for things that are unlikely to happen, but if they happen, they're so catastrophic that we have to prepare. This subordinated all our other national priorities. We cannot allow something like this to hit us this bad again. So we have to prepare differently domestically. But internationally, what that means is we've historically relied on international conventions and capacity building in other nations, basically going into nations that would be hot spots and trying to build capacities in those nations as a way to create an early tripwire to warn us of an emerging disease. We rely on other nations to tell us when they have an outbreak. That has repeatedly failed. It failed in this case. China didn't surface the early information. They still haven't shared the source strains, but we can go through a litany of country after country that was host to novel outbreaks of SARS-like viruses, novel outbreaks of influenzas, novel outbreaks of Ebola that didn't surface the information in a timely fashion. And so the question becomes, can we still rely on the international health regulations and the WHO and the World Health Assembly? Are we going to all hold hands again and promise that we really mean it this time and we're going to share information? Or do we need to get our clandestine services more engaged in this mission? And I think we're going to need to get our clandestine services more engaged in this mission. And it's one of the things I talk about because that's a very big departure from where we've been in the past. In the past, there was always an assumption that the public health mission was the CDC's mission. The CDC and the public health officials didn't want the spy agencies anywhere near that because they felt it would corrode their authority to act outside the U.S., that everyone would be perceived as a spy. And traditionally, the national security agencies said, the CDC has this. This really isn't our mission. It was seen as a sort of a softer aspect of the overall national security mission. I think that needs to change. I think given what we've seen, not just how this impacted us, the death and disease, how this changed the course of history, the geopolitical impact. Would China have moved on Hong Kong if the world wasn't distracted by COVID? So we can't allow something like this to happen again. And we're going to have to get our spy agencies involved. There was data very clearly available in China, in Wuhan, that if we were looking for it, we could have detected this much sooner. We could have answered some key questions. We could have seen the asymptomatic spread. We could have seen the human-to-human transmission. There was sequence data that was being flying around by mid-December inside China, and probably earlier than that, being sent to commercial labs. That signals intelligence that could be intercepted if you know what you're looking for. So there was a lot of information that could have been had. And in the hands of good political leadership, you could have had some key questions answered early that could have allowed us to mount a more robust response. And a 2 or 4 week head start on something like this can make a very big difference.
On the intelligence front, you said you talk about a lot of this sort of towards the end of your book, and this is a more current conversation about the origins of COVID. The president ordered this 90-day review of intelligence, and it came to basically no conclusion. What did you learn in the course of your research about the origins of COVID?
I learned that we're not going to answer this question absent one of two things happening. Either we find the intermediate host, the animal that was that spread COVID, or there's a whistleblower inside China, or someone close to this who knows that this came out of a lab, comes forward, defects, goes overseas, or we intercept some communication that we shouldn't have had access to. Absent something like that, we're not going to be able to answer this question. This is going to be a battle of competing narratives. I think over time, the side of the ledger that says that this might have come out of a lab has grown more robust, and the side of the ledger that says that this came out of a natural species has not really moved. And if anything, you can argue that side of the ledger has been diminished by a couple of facts. Number one, we've looked for the intermediate host and we haven't found it. And number two, the idea that the market, this initial market, was the source of the initial spread has been firmly debunked. Even the Chinese acknowledge that. And that was a big part of the thesis around the zoonotic origin, the animal origin, because the idea was that the animal was in that market.
Right.
We now know that market wasn't the source of the spread. It was a path along the spread.
Beijing has even acknowledged that.
Beijing has acknowledged it, right.
When you say intermediate host, you mean what happened between the bat and the human? Who
Right.
came in between?
There's an animal. It's maybe a pangolin. There's some other animal in between, and it could have been. It wasn't necessarily a bat, and it could have been a bat to a human. But we haven't found the virus in nature, and there's been a pretty exhaustive search. The Chinese have mounted an exhaustive search, and I don't think that the fact that they've been looking for it proves that they know it didn't come out of a lab. I think that they would be looking for it even if they knew it came out of a lab. And the reality is, if it came out of a lab, the number of people who actually are aware of that could be a very small subset of people.
When you say came out of a lab, you were saying through a lab accident, not a construct.
Yeah, no, I don't think anyone, and the administration has said this in the intelligence report they put out, that they don't believe, they've sort of firmly debunked the idea that this was something that could have deliberately come out of a lab or was deliberately engineered. But the possibility is that you've had labs doing research on novel coronaviruses. You had novel coronaviruses being brought to those labs, particularly the Wuhan Institute of Virology. We know that they were doing that research in what's called BSL-2 labs, lower security labs where tight precautions aren't taken. We now know that they were infecting transgenic animals with coronaviruses, with novel coronaviruses, as part of their
Transgenic
research.
meaning
Animals with
partially human.
right, animals with human immune systems. So that again is another step that makes it more likely that it could have spread to humans, because now you're infecting animals with human immune systems, so they're humanized viruses. You're adapting the viruses to animals to try to infect the human immune system. All those set up the conditions for risk. And we also know that the Wuhan Institute of Virology was a sloppy lab. At the time that it opened, there was an article in the journal Science raising questions about the integrity of that lab, where scientists at the time that it opened in 2017 said, we're worried about the procedures in this lab. We're worried about the training. We're worried about the way it was built. We know that the lab was conducting high-end research with the Chinese military. The French were in that lab and were eventually kicked out. And at the time that they were kicked out, they were aware that the Chinese military had moved into that lab. So there were the circumstances created around that facility, and there were operating procedures around that facility that created a lot of risk. That doesn't mean it came out of the lab, but it certainly makes that a suspect location. And there was another lab, the CDC, the Chinese CDC maintained a lab literally blocks from the wet market that was first implicated in this virus that was also conducting coronavirus research in BSL-2 labs.
So, other than the whodunit factor, why does it matter? Why do we need to know who patient zero is, and how will that affect the Biden administration's response?
Yeah, it matters a lot, because if we determine that, first of all, if we determine that this came out of a lab, or we even assess that there's a high probability that this came out of a lab, I think it changes how we try to govern research internationally. We're going to need something like the International Atomic Energy Agency for BSL-4 labs. We're going to have to look much more carefully about who's creating BSL-4 labs, the kind of research going on in those labs.
That's the UN?
It's going to probably be a global organization, come out of the World Health Organization, some kind of international consensus around providing oversight on these labs, because there's a lot of them cropping up right now. A lot of countries are building BSL-4 labs and starting to engage in this high-end research, and the most speculative, most dangerous research often goes to the countries willing to conduct it, and the countries willing to conduct it are oftentimes the countries that have the poorest controls. The other thing we're going to need to look at is, do we continue to do things like publish the sequences of novel viruses? So when labs create novel compilations, when they create a novel virus for purposes of trying to assess what activity it could have in humans, once you publish that sequence as part of normal scientific discourse and part of the scientific process, you basically provide a recipe to anyone who's a rogue actor on how to manufacture that virus. And I think we're going to have to look at whether or not that's a good idea going forward, and maybe not publish information like that, have a consensus that we're not going to publish that kind of information. Because the other thing that comes out of this is that this hurt us a lot more than it hurt other countries. It hurt the West a lot more than it hurt other countries.
Why?
We proved uniquely incapable of implementing respiratory precautions, getting consensus around things like mask wearing, the mitigation that was required. A lot of countries did better than us. A lot of countries in the Pacific Rim did better than us. And the old doctrine was that no country that's trying to develop a pathogen for a deliberate purpose, as a bioweapon, and this wasn't a bioweapon, this very clearly was not a weaponized virus, but going forward, a rogue actor that's looking to develop a biological weapon, the presumption was they wouldn't use a respiratory pathogen because it would blow back on them. But now, looking at how this disrupted the West relative to other parts of the world, I think that calculus needs to be reassessed. And so it raises the stakes around the risk of doing this research, allowing this research to go on, publishing things that could facilitate this research, if we know that there's rogue actors that might be, on the margin, more likely to look at a novel influenza as something that could potentially be weaponized. And even if you could just develop a respiratory pathogen that could disable a group of people, or make people sick for 3 or 4 days, that might be a weapon you use on troop movements. So we need to think differently about these risks now, having seen how this disproportionately impacted certain countries relative to others. This was an asymmetric risk to the West and to the United States in particular relative to other nations.
Who handled this the best on the global scale? Which countries?
Well, it's a tough question, because there were certain countries that kept the virus out, or were able to preserve life. But
Australia.
But the question becomes, what price did they pay for that in terms of what they imposed on their population, the economic impact? I think if you look at some of the countries in the Pacific Rim, like Singapore, Taiwan, South Korea, they handled it very well insofar as they didn't adopt all the same draconian measures that countries like China did, where they locked down the entire country, but they were still able to maintain control over it. And in South Korea's case, they did it through very aggressive testing and tracing. They employed certain aspects of their state apparatus to basically collect information on people that wouldn't have been feasible in a Western democracy. We would never have tolerated it. But I don't think people always point to that and say, we couldn't do what South Korea did because they used their police state to basically monitor people. That was a small aspect of what they did. I think the core of what they did was really deploying testing on a massive scale, encouraging people to get tested. They literally had testing devices for sale in vending machines and subway stations, and using that as a way to get people diagnosed and then encouraging people to get into quarantine if they had the infection. That was the core of what they did, and they did it successfully.
Who didn't handle it well? I mean, do you put the United States on the list of worst responders?
Well, I think it's hard to say who handled it the worst. I think that we're at the top of the list of countries that were the hardest hit by the pandemic for sure, and had a very difficult time putting in place the measures that were going to help control the spread.
Is that simply just because we track what's happening? I mean, is that an unfair criticism to say the United States?
No, I think there's good enough global tracking among a lot of our counterparts that we can make an assessment that we were disproportionately impacted by this. I mean, there were certainly countries that had a higher death rate on a per capita basis. There were countries as hard, if not harder hit. But of the industrialized countries, where there was an expectation that we'd be able to do better, where we had tremendous capacities, where we had a very good healthcare system, where we had access to the technology, we had the ability to develop therapeutics and vaccines and get early access to them. Relative to what our asset set was, we did pretty badly with this virus.
In terms of, are we better now? You wrote that the virus rode in on the breath of hundreds of thousands of travelers. Both Presidents Biden and Trump put in travel restrictions. Would you tell the Biden administration now to lift them? Because you're arguing they're largely ineffective.
Well, they're largely ineffective now. I mean, I think that if we're going to put in place a travel restriction, you could defend a travel restriction that requires people to be vaccinated to come into the country. If we're trying to create a bubble around activity in this country and putting in place our own mandates around vaccination, it makes sense to require people to be vaccinated if they come in. That's something I think that's defensible. But the idea of broad travel restrictions based on region, when there's just as much virus here as there are in the parts of the world where we're restricting access, I don't think that makes sense anymore. The travel restrictions had limited value early on. I think we over-relied on the travel restrictions, and we thought we could actually erect walls and keep this virus out or keep it out for longer than we could. We couldn't. They weren't nearly as effective, I think, as people assumed, or even people now sort of surmise. But there was some logic in putting in place some travel restrictions early when we knew that there were specific countries. Italy, in particular, was heavily seeding New York. Obviously, people traveling from Wuhan, where there was a raging epidemic. Those kinds of restrictions made sense at the time. At this point, there's so much virus around the world, I'm not sure what we're keeping out. We're more likely to have restrictions imposed on us than be in a position of imposing restrictions on other nations.
Well, you also make the argument that that can backfire because you say then countries are basically not incentivized to come clean.
Well,
They're incentivized to cover up what's happening.
Right. This gets back to the question of, will we need to rely on our clandestine services more to gather information? So if we go into this, and we've already started down this path, and we go back to the World Health Assembly, the WHO convenes a meeting, everyone comes together and says, we really mean it this time. Now we're going to, if something like this emerges again, we're all going to agree that we're going to share the data, we're going to share the source strains. Well, what did COVID teach the world? COVID taught the world that if you're host to an emerging infection that looks threatening, the first thing other countries are going to do is erect trade and travel restrictions on you and try to isolate you. Like before COVID, that was controversial. The idea of actually isolating a nation was highly controversial because there was a presumption that if you isolate a nation that's host to an outbreak, you'll destabilize that nation and make it harder for them to combat the outbreak. But what's the first thing that happened when the British said, we have this concerning new strain of COVID called B117 that seems more contagious? The French closed the channel. Right? So now we've taught nations that if you come forward and raise your hand that you're host to an outbreak, you're going to face some kind of sanction for that. So if that's the case, how can we rely on countries being forthcoming? We're going to have to rely much more on our ability to actively gather the information we need of an emerging outbreak and not just hope that people tell the truth and tell it in a timely fashion.